Thank you very much, Clinton, for inviting me and Chairman to give me this talk. It's a bit controversial, so it's what we have learned from MitraClip trials. We're all in a surgical audience. I felt quite challenging to go through things, but anyway, these are my disclosure. I'd like to start with a bit of background, saying that obviously success in transcatheter aortic valve replacement has led to high interest in transcatheter mitral valve repair implantation. So the technique that we have to treat the mitral valve with transcatheter technique are essentially three. As has been said before, repair, valve-in-valve, involving ring, and replacement. Repair, the industries try to emulate what we do in a surgical operation. The most successful device has undoubtedly been MitraClip. Mitral valve in ring and mitral valve in valve are procedure for patients that already have a previous cardiac operation, and then a replacement where the number of transcatheter mitral valve replacement is essentially much lower than TAVI, even though the landscape for development of this valve is very highly and competitive. And in fact, this is essentially what has been said before. The industry are putting a lot of money to develop new technique. There is a high interest to develop this new technique. Anyway, let's go back to MitraClip. See, this is how the device looks like. Essentially, the device has two arms to grab the posterior and anterior leaflet of the mitral valve and is emulating the Alfieri stitch, famous Alfieri stitch. The procedure is done transfemoral vein, and then transeptally, and then you go across the mitral valve, grab the leaflet, and close the device. Now, what are the evidence behind it? There's a very large number of these devices implanted. Unfortunately, UK, not so many. There's been a first randomized control trial, Everest, that published a result of 5 years in 2015, and then followed by two trials within 2 weeks of each other that unfortunately have discrepancy result. And so to understand the need of this two trial, we have to go just very briefly through Everest trial 2. Just a slide to notice that there's been a big gap between Everest 2 and MITRA-FR. So Everest 2 essentially is a randomized control trial. They enrolled 279 patients with significant MR, and they were randomized 2-to-1 between percutaneous mitral group and surgery group. So they have a MitraClip, they had 184 patients, and surgery group at 95. And they've been followed up to 5 years. So the result of this trial are very well known. Surgery is superior for freedom from mitral valve regurgitation and needing of reoperation. But if you see the result of survival at 5 years, there is no difference. So the conclusion of the trial was the MitraClip is a very safe device, but the efficacy of the device is significantly higher in the surgery group. But looking in subgroup analysis of this trial, there was a particular group, didn't have many patients, is around 40 patients, where MitraClip actually was performing better than surgery. And this is patients with functional MR. And that's just to answer my first question. Why did we need another trial? It's just to answer this question. Is MitraClip useful for these patients with functional mitral regurgitation compared to optimized medical therapy? And what about MitraClip versus surgery in these patients? Obviously, there's no trial on the last point, but let's see what has been published on the first point. So, two trials came out. The first presented was on 27th of August, ASC. It was MITRA-FR. This trial was funded by French government. Second trial, a couple of weeks later, 23rd of September, a TCT sponsored by Abbott. So let's go to the trial to see what they say. Essentially, MITRA-FR, they had 304 patients at 37 sites. It was 12-month trial. They enrolled patients with significant functional mitral regurgitation by European guideline, with reduced left ventricular function between 15 to 40%. They all had hospital admission in the last 12 months, and they were optimized medical therapy just after the enrollment in the trial. There was no hard team decision. So they randomized 1-to-1, 152 patients, MitraClip plus optimal medical therapy, and the whole control group, it was just optimal medical therapy. So what they found? The primary endpoint was death for any cause and unplanned hospitalization for 12 months. So essentially, this trial said that there is no difference between the two groups. You see, for a composite primary outcome, death and hospitalization, 54% in the MitraClip group, 51% in a control group, death, 24% in the MitraClip group, and 22% in the control. Unplanned hospitalization, 48% against 47%. So essentially, among these patients, percutaneous mitral valve regurgitation repair was not beneficial. This is the conclusion of the trial. As I said, only a few weeks later, another trial came in, a COAPT trial, 614 patients, 78 sites in US, Canada. It's a trial lasts 2 years. All the patients enrolled in this trial had a moderate to severe functional mitral regurgitation. This for America, following American guideline. All the patients were already optimized for optimal medical treatment. And there was 1-to-1 randomization when the patients were not appropriate for conventional cardiac surgery. So they had 302 patients in device arm and 312 patients for medical therapy. What are the first endpoint? Primary endpoint is a recurrent of heart failure and hospitalization. And there was a primary safety endpoint, freedom from device-related complication of 12 months. Then there was 10 separate endpoints. So the conclusion of this trial says that there was up to 46% reduction in hospitalization and 34% less mortality in MitraClip arm. So also freedom from device-related complication was excellent. So that really, and you can see the mortality is much better in the device group. So the conclusion of this device, they had lower rate hospitalization and lower cause of mortality at 24 months, significantly both of them. So essentially, how we can explain that? How is two similar trials have such different results between them? Essentially, I try to understand the difference, just answering these four questions that I have here. Are the patients in these two trials similar to each other? Essentially, the answer is no. If you see, the severity of mitral regurgitation in patients in the COAPT group is more severe. They have a fatigue regurgitatory reflex area of 41 compared to 31. And also the dimension of the ventricle in COAPT is they are smaller compared to MITRA-FR. Essentially, MITRA-FR seems like they've been treated patients that had more ventricular problem rather than mitral valve regurgitation related issue. And in fact, in the subgroup on COAPT, in the COAPT trial, where the mitral regurgitation was less and the ventricle is dilated, this can show clearly that there's no difference between the MitraClip group and control group. So different procedural result. Yes, essentially in MITRA-FR there were many centers that didn't have much experience in MitraClip compared to COAPT trial. They have all centers with high volume, and the result of residual mitral regurgitation between the two trials showed that COAPT had only 31% of mitral regurgitation, more than 2, after 12 months, while MitraClip had 44%. Study duration and follow-up. Yes, you can argue one study was 2 years, one study was 1 year, but even if you draw a line at 12 months in COAPT trial, you can clearly see that the two results are different. There's still significantly less complication rate in device group. Study follow-up was excellent in both trials, 94% in COAPT and 99% in MITRA-FR. But the difference for their own admission on MITRA-FR manuscript say that unfortunately substantial amount of echocardiography data were missing at 12 months. So we cannot confirm a durable result of percutaneous repair. Truly optimize optimal medical therapy? Unfortunately, as I said to start with, in MITRA-FR, they changed medication over the trial. So the patients were not optimized before being randomized. So they allowed patients to increase their medication during the FI. We don't have any information about that. So it's very difficult to compare these two trials. So what we can learn from a COAPT trial? I think that's MitraClip is not the perfect device. It can be applied to all the patients, but it should definitely be considered as an adjunctive therapy when surgery is excluding and the patients are symptomatic with optimal medical therapy. Maybe patients with less MR are less likely to have benefit from the device. Patients with the worst left ventricular function are less likely to have a benefit from this device. And perhaps once we perform this procedure with MitraClip, we shouldn't accept moderate mitral regurgitation. We should really go for it, and we should really try to treat the mitral regurgitation, reduce as much as we can. There are any alternative? Of course, we know the surgery is an alternative, but when we see the study comparing surgery and medical therapy in very sick patients with functional MR and poor ventricular function, we know the results of surgery are not very good. And in particular, when we discuss ischemic mitral regurgitation, the result of mitral valve replacement is better than mitral valve repair. So this makes me think there is another way, less invasive, to treat these patients overall ischemic with ischemic and functional mitral regurgitation. Yes, there is, like is transcatheter mitral valve replacement. Although the numbers are much lower, and this is due to much more complex procedure for several reasons, essentially, because the mitral, compared to the aortic valve, the mitral valve is much more complex. We have to have many more parameters to consider, like annulus shape, subvalvular apparatus, length of the leaflet, thickness, LVOT dimension. And also there are a lot of technical challenges, like sizing, fixation, sealing, and delivery. But this doesn't discourage us because there's been now 24 companies involved in the process of developing the new valve, and there are 25 products out there, of which 5 are still very viable, of which the more successful one is definitely the Tendyne valve. So in conclusion, COAPT show us encouraging result, but this has to be replicated in the future trial. Careful patient selected can have an advantage by this treatment, but this is definitely have to have a hard approach team involved, and the operator experience is paramount. And transcatheter mitral valve replacement is developing and is very promising. I will just give a big thank you to my transcatheter mitral team at the Royal Brompton Hospital, in particular to Rob Smith, that is leading MitraClip in our hospital, Rashmi Yadav, that co-lead the transcatheter mitral program with me, and Dincher Artuge, that is our transcatheter mitral valve fellow. Thank you.